This recording is going to cover another cardiovascular regulatory mechanism, specifically looking at the regulation of blood pressure. We're going to look at the role of the nervous system as well as renal and hormonal mechanisms by which we control blood pressure. The question is, why is it so important to control blood pressure? If your blood pressure is too high, it can damage blood vessels because capillaries are so thin. Now, if it's too low, you're not going to have a proper pressure for perfusion of tissues. So you don't want it too high, you don't want it too low. We pretty much want to keep a relatively constant level of perfusion to tissues. Now, but we do want to allow changes in flow in organs. Some organs, like say during exercise, you want to increase flow to one organ, you want to decrease flow to another, but you don't want to have changes in those local changes in blood flow to adversely affect your blood pressure. You want to keep that pressure about the same. Now, the way our bodies are designed, the way our cardiovascular system, our blood vessels are arranged, is that your mean arterial pressure is about the same for every tissue. So it's real important that you regulate it. So again, those changes in flow don't affect that blood pressure. Now, there are going to be nervous system reflexes, which are very short term. They act very quickly. And then we'll look at the role of the kidneys and hormones. They regulate not quite as quickly, but they're more long-term regulation of blood pressure. Now, as a reminder, for the equation for blood pressure, mean arterial pressure, that average pressure in your circulation, which is an important perfusing pressure, is equal to your cardiac output times total peripheral resistance. And as a reminder, cardiac output, we can write as stroke volume times heart rate. So here is just another way of giving you that equation for blood pressure. So according to that equation, changes in either of these, barring, or should say, if I increase any of those without changing the others, blood pressure can go up. If I decrease any of them without changing the others, blood pressure can go down. So changes in these have direct effects on blood pressure. Again, assuming that, for example, I'm going to give you an example right now, is if, for example, I increase cardiac output, but I decrease total peripheral resistance, blood pressure may not change. Okay, so that's kind of important to think about. Okay, so despite, and a great example is during exercise, where you have a drop in resistance in those working muscles, your blood pressure does not bottom out during exercise because of various control mechanisms that we have in place. Okay, so let's kind of look at big picture, the nervous system control of blood pressure, and using again the terminology when we talk about homeostatic regulation, looking at reflexes. And the first thing we'll be looking at is something called the baroreceptor reflex, which is important in short-term regulation of blood pressure. So with homeostatic regulation, you always have some sort of variable. So the yellow here represents the variable. In this case, a change in blood pressure. Now, what detects the change in blood pressure? It would be a receptor. In this case, it's what we call baroreceptors. Now, baroreceptors are going to be located up here. This here is the carotid sinus. Got a large amount of them there, because that's going to be monitoring pressure that's going to the brain, because it's important to have proper perfusion for the brain. And you also have them here in the aortic arch, because that's monitoring that pressure going to the rest of the body. So we have baroreceptors to detect that change. That change is detected, but then sent to an integration center, and that diamond is the integration center. And in this case, this is your medulla oblongata. Doesn't want to write it up. Now, how did it get there? Well, we have to have afferents, and I'm going to put this here for afferents. You have to have some sort of afferent pathway. In this case, these are going to be using afferent neurons, and what will be involved is 2 of your cranial nerves. I'm just going to erase this real quick. Okay, so I'm going to go back here because it's going to get too busy. So here in the blue, this one right here is cranial nerve 9, the glossopharyngeal nerve. So that's cranial nerve 9. And right here is the vagus, cranial nerve 10. They're going to be sending that information up to the medulla oblongata. Now, in the medulla oblongata, you have 2 centers. You have a cardiac center and you have a vasomotor center. The vasomotor center is going to affect the diameter of those arterioles. The cardiac center has 2 different components to it. It has, I'm going to write it down here, we have a cardio acceleratory center and a cardio inhibitory center. I'm going to come back to that in a second. So we have a variable, you have receptors, you have afferent pathway, you have an integration center. Well, once the integration center knows, okay, blood pressure has changed, I know what I need to do or tell people to do to get that blood pressure back to where it's supposed to be, and we're going to use efferent pathways. So the purple are going to represent efferents, and our 2 efferents would include the vagus. That's going to have parasympathetic nerve fibers, and it will also include the sympathetic nerves. What they do, or they're going to influence the effectors, so the light blue represent the effectors. So the effectors include the heart and blood vessels. And so heart rate, cardiac contractility can be affected, which affects cardiac output. The arterioles, the diameter of arterioles be affected, which would affect total peripheral resistance. Now the cardioacceleratory center will affect heart rate and cardiac contractility by affecting the heart via the sympathetics. The cardioinhibitory center will decrease cardiac output by the parasympathetics, and specifically the vagus. Now the vasomotor center, it will affect the diameter of blood vessels, and if you have increased firing rate from the sympathetic nerves to arterioles, that would cause vasoconstriction, and it's by binding to the alpha-1 adrenergic receptors. So the diameter, though, of arterioles will be determined by the firing rate of those sympathetics. Increased firing rate would cause constriction, decreased firing rate would cause dilation. So what we're going to do is we're going to go through some scenarios and see what happens, what's involved in these various baroreceptor reflexes. So first scenario that we're going to talk about is there's been an increase in pressure. Example would be if I go a change in body position, but this would be, say, go from standing up to lying down. That would do it. You can have an increase in pressure as a result of, say, external compression over the carotid, which actually is used in some of the martial arts. Is people know they're taught certain points to press on the neck, that will elicit a reflex, and it's so exaggerated it causes them to pass out. So we're going to think about it when I talk about what happens here. So what the scenario is, somehow pressure has gone up, and the baroreceptors detect this. Here you're specifically looking at the baroreceptors located in the carotid sinus, but both the aortic arch and carotid sinus baroreceptors will detect an increase in pressure. What happens is there's an increased firing rate, and I'm just going to abbreviate FR for firing rate. There's an increase in firing rate from these receptors, and so this is traveling along the cranial nerves 9 and 10 up to the medulla oblongata. So the vasomotor center will respond. And as a result, so I'm going to write this down so we can see. It's like, what blood pressure has increased, what can I do to get that blood pressure back down? So let's affect any of these things to try to get that blood pressure back down to a normal range. And so what's going to happen is, let's affect the total peripheral resistance. So if pressure increased, how could I get pressure to go down? Well, I can do that by decreasing total peripheral resistance. And so what's going to happen, there's going to be less firing of the sympathetic nerves to those arterioles. And as a result, you're going to get vasodilation. So we're going to make this blood vessel a little bit wider here. And so with vasodilation, you get a drop in resistance, which helps to get blood pressure down. We also have the effects on the cardiac center. So increased firing rate on the cardiac center results in an increased activity of the cardioinhibitory center, and you have a decreased activity of the cardioacceleratory center. So what happens? Well, you'll have increased vagal activity, increased the firing from the vagus nerve, less firing from the sympathetic nerves, and what happens as a result? So you're more parasympathetic, less sympathetic, heart rate decreases, cardiac contractility decreases, which decreases stroke volume. And so all of these together would help to get that blood pressure back to about normal. So this is one example of a baroreceptor reflex. But this baroreceptor reflex works in both scenarios, if pressure went up or if pressure goes down. So let's look at the scenario if your blood pressure has dropped. So here, okay, so blood pressure is decreased. What could cause a blood pressure decrease? Again, a change in body position, but in this case, you're going to go from lying down to standing up. And what happens is when you stand up, blood pulls to your feet because of gravity. And what will happen really quick is that pulling of that blood to your feet causes a decreased return of blood to the heart, decreases cardiac output, and can decrease your blood pressure. But this reflex is going to be so quick, most of you won't even know that your blood pressure initially dropped because it's going to get it back to normal. But those of you who change body position, go from lying down to standing up, and you may get like that black, kind of like almost a blackout over your eyes, it's because your blood pressure is dropping and that reflex is not so quick. And so some people, when that happens, they know that, so they change body positions a lot slower so they don't pass out. Because if your blood pressure drops too low, you'll pass out. And so with this reflex, what's going to happen is the drop in blood pressure, the baroreceptors detect it, and they have a less firing rate. So there's a less firing rate going up to that medulla oblongata. And what's the response of the vasomotor center? Well, in this scenario, the vasomotor center is going to be more active. You're going to have, doesn't want it right in here. So increased firing rate to those blood vessels, the arterioles, what's going to happen is you're going to get vasoconstriction. So you see that diameter getting smaller. So you have vasoconstriction, which increases resistance. So let's write this equation out again. Heart rate times stroke volume times TPR. Resistance increases. What about the cardiac center? Well, the cardioinhibitory center is going to be less active. The cardioacceleratory center is going to be more active. So what happens is less firing from the vagus, more firing from the sympathetic nerves, and as a result, heart rate increases, cardiac contractility increases, which results in increase in stroke volume. So all of these things together would help to get that blood pressure back up. And so this is a baroreceptor reflex. A lot of people, they never realize that their blood pressure changes when they change body position, because this reflex is so quick and so good, we usually don't know that our blood pressure actually really changed just a little bit, but this thing responds, so you never even know anything happened. Now, one thing I do want to mention before I go on is it's still important that you know the receptors located on the heart that respond to either the neurotransmitters released by the sympathetic nerves or by the neurotransmitter released by the vagus. So the sympathetic nerve fibers will release norepinephrine, which on the heart you have beta 1 adrenergic receptors. The vagus releases acetylcholine, which binds to muscarinic receptors. So I want to why again, I think it's important that you remember these things, is I want you to think about people who are on beta blockers, for example. People who are on beta blockers are told to change body position slowly because it will affect the baroreceptor reflex. They don't tell them it's going to affect your baroreceptor reflex because they'll be like, what are you talking about? But think about what would happen with someone who's on a beta blocker and they went from lying down to standing up. That baroreceptor reflex that should elicit as a result of that initial drop in blood pressure is not going to be as effective because you're supposed to have more activity from the sympathetics to the heart, and you're not going to be able to increase that heart rate and stroke volume as much because of the fact they're on those beta blockers. You're going to still have an increase in resistance because the alpha-1 adrenergic receptors on the blood vessels won't be affected by the beta blocker, but you might need to have the change in the cardiac output as well as resistance to get that blood pressure back to where it needs to. Otherwise, they're going to get very lightheaded when they stand up. So people on beta blockers need to be told to go from lying down to standing up a little bit slower than they may have done in the past. So just so you know. Now, what about long-term control of blood pressure? Well, the kidneys play a very important role in the long-term control of blood pressure. And I should say blood volume does. So things that affect blood volume. So short-term, lots of times it's more effective when you look at changes in resistance. Long-term, it's about blood volume, which can affect your cardiac output. So the kidneys play a real important role. So I just kind of want to mention that, say, in your kidneys, here's your glomerulus, which are fenestrated capillaries. You're going to have filtration of stuff from your blood. I always say the good, the bad, and the ugly. You're getting rid of waste products, but you're getting rid of, or you're filtering things like glucose and amino acids. You'll get them back. Trust me, you're going to get them back. But that kidney is like, I need to have a proper pressure to filter out the bad stuff. And if for some reason the pressure is not adequate here to be able to get that filtration out, get that stuff out, there will be a dramatic response by that kidneys to get pressure up high enough so it gets a proper filtration. Kidneys don't care about anybody else but itself. It's like got blinders up. My whole goal in life is to get rid of waste products. So if I'm not getting an adequate pressure here, I'm going to do whatever I can to get pressure up so I can get that stuff out. So I want you to think about what possibly could happen. Okay. So I'm going to show you, before I do that, here, I'm going to show you something. I'm going to draw a graph for you. I'm going to have to do it in a very small space. I'm going to show you what is a renal output curve. So it shows the relationship between mean arterial pressure and, over here, urine output. And I'm going to draw it kind of like this. There's a minimum level of pressure you need to have a urine output. And I'm going to say at a normal pressure, about 90 something, between 93, 98 millimeters of mercury, this would represent your normal urine output. Now, if you look at that curve, what would happen if my mean arterial pressure went up? According to this, if you look here, my level of urine output goes up. Okay? So, and I'm going to look at what we're seeing without any external factors, just the kidneys by themselves. Now I'm going to look at any nervous system, nothing. So what would happen is mean arterial pressure increases, urine output will increase. Because if pressure increases, you're going to filter more fluid out of those glomeruli into the kidneys, and if that increases, something we call your glomerular filtration rate increases, the rate of filtration increases. Things are going to move those nephron tubules real quick. I may not have time to get all that fluid back, and so the level of fluid in my urine increases. And what will happen though, as long as everything's working fine, is if I'm losing more fluid in my urine, my blood volume is going to decrease, which decreases venous return, which decreases cardiac output, which would decrease your pressure. And that will continue until you get back to the set point. I'm going to say right there. The kidneys will respond to an increase in mean arterial pressure by what we call an increase in diuresis. You have an increase in urine output. You also do get an increase in sodium output too, but we're going to concentrate mainly on the urine, the level, the volume. Now, if your blood pressure dropped, if you look at the curve, if my blood pressure, say, dropped, look what happens to my urine output. It decreases. Well, what's going to happen as a result of that is if my urine output decreased, my blood volume would go up. Increase in blood volume results in an increase in venous return, increased cardiac output, and an increase in blood pressure to back to where it's supposed to be, to normal. So assuming that your kidneys are working properly, what will happen is changes in blood pressure would result in changes in urine output, which would eventually get our mean arterial pressure back to where they're supposed to. Your kidneys, believe it or not, determine your preset blood pressure. And it's the nervous system that regulates towards that preset blood pressure, which is determined by your kidneys. And again, I have to emphasize, assuming your kidneys are working appropriately. Now, what's the role of other factors? And again, they're linked to the kidneys in controlling your blood pressure long term. So here, this is some of the stuff I had mentioned previously, is, for example, your blood pressure dropped, and your blood pressure drops. The kidneys, I said, remember, they're like, oh, I don't like this. I'm not going to have an adequate pressure to be able to get that perfusion like I should. So I'm going to do whatever I can to get that blood pressure back up. And so it releases renin. And renin converts angiotensinogen to angiotensin 1. That's then converted to angiotensin 2 using this enzyme here. Angiotensin 2 is it does a number of different things. The angiotensin 2 has effects on the kidneys, it has effects on the adrenal glands, it has effects on the brain, it does a number of different stuff. So I'm going to give you all the different things that it does. Angiotensin 2 is a vasoconstrictor. It also will do things to cause the pressure, and specifically that perfusion pressure, to increase in the kidneys because it affects on certain blood vessel there. And I'm going to wait till a later date to talk about that. But it will get that pressure up in the kidneys by direct affecting what's going on in the kidneys. But it's also a vasoconstrictor in other parts of your body. It increases aldosterone, which you see on the picture, but I'm just going to write it again. Aldosterone secretion. Aldosterone, remember, increases sodium reabsorption. And as a result, if the part of the nephron tubule that's responsive to aldosterone is also permeable to water, water comes along with it, and that will help to increase blood volume. It also increases ADH secretion, and ADH is a vasoconstrictor, plus also it limits water loss, and so you're going to hold on to more fluid. And another thing it does, it increases thirst. So all these together will affect blood pressure. It's going to affect blood pressure by affecting resistance, but also affect blood pressure by affecting blood volume, which affects cardiac output. So just as to kind of so you understand the role of the angiotensin, or I should say renin-angiotensin-aldosterone system in blood pressure regulation, is that a lot of medications given to people with high blood pressure target different components of this system. There's receptor blockers for angiotensin 2. There are ACE inhibitors that they're given. They also can give mineralocorticoid receptor antagonists. So there's a lot of different things that they give to try to reduce blood pressure by affecting various components of this system. So the hormones, a couple I just mentioned, that can affect blood pressure are the same ones we talked about that could affect blood flow. So angiotensin 2, which I just went over, that affects, and I'm going to say, I'm going to list, how does it affect the blood pressure? Does it affect resistance, and or could it affect the cardiac output aspect? Angiotensin 2 does both. I just mentioned that. It affects resistance, and it can affect the cardiac output aspect. The adrenal medulla secretes norepinephrine and epinephrine. That affects cardiac output and resistance, so that is both. So they increase cardiac output, and they can increase blood pressure. ADH affects both. It affects resistance because it's a vasoconstrictor, but it also affects water balance, so it affects cardiac output because it affects blood volume. Now, a third thing, which I hate talking about, is the heart produces atrial natriuretic factor. You may also hear it as atrial natriuretic peptide. That can that decreases blood pressure because it triggers an increased loss of sodium by the kidneys. And then if you're excreting more sodium, water kind of follows with it, and so that can actually decrease your blood pressure. Okay, so this one primarily just affects the blood volume part, or say cardiac output. Okay, so this is the last part of regulation of blood pressure. Another recording will look at cardiovascular responses to exercise as well as hemorrhage.